Hey everyone, it's really a privilege to be able to just kick things off with such great programs listed here, and I don't think I've ever seen since this collaborative formed all the programs in the Carolinas pulled together like this. So it's a privilege, and I'll be very efficient here because I think the biggest part is hearing from you all. The main thing I think John was calling on me to do here is sort of like a call to action. I will say the output here, you'll hear it better from the team, but I think in the end, we really want to explore what outcomes we're looking at. How can we share across programs? But probably most importantly, how do we have a framework and a trajectory going forward? And so I won't go through these things, but to say, and this is not a framework here I'm proposing at all, it's just my experience. I've done a lot of work with Charter United Way over the years, nonprofits, Duke Endowment, Levine Foundation, wonderful work I've been lucky to have. I've been supported in a lot of the work that our team has done with state appropriations. I can't tell you how lucky I think we've been to be where we are. Um, but what I found over the years is data is hard. And I think what you'll see in your presentations is great process indicators. I think we're getting all more mature at how we're doing those kind of things. I think as we move towards figuring out decision making going forward in your strategy, I'll even say less than trying to defend your programs and get funding, even though that's an important aspect. To me, that's not what drives me and what should drive our data discussions. It's really, how do we not repeat the nonprofit cycle of helping out for 10 years and making incremental progress, getting defunded, coming back, and not being able to build upon previous experience from your own program or other programs. And so I think as you move forward into this, understanding that one, as you get your data and you share, you're likely to have windows of opportunity when you can do robust data. And the work that we do, the safety network that we do with the kids that we're trying to serve, kid by kid, that you're making a difference. That is very hard at times to pull that out and show that in a peer-reviewed study and something that can help validate. It doesn't mean that's not happening. It means that you need the academic strength and the sample size to be able to adjust for confounders. And then even once you do that, what's even really harder is to repeat yourself. So every few years, you really should be doing robust analysis if you're really going to have a program that is heavy on social determinants of health and other confounding impacts to get there. So I think everybody knows that. So I think that's where I get sort of fired up and passionate about data is this is my kid going to school. I think last year, one of my kids, I got a bunch. And so, when I think about my own kids, what I don't want is them to have kids and somebody studying it the same way I'm studying it now. I want to make sure that we make incremental progress, and at MUSC, we've done some good studies in the past, but it's really hard to get the ability to repeat them. So I think what John and team are pulling together are academic strength from our different institutions, the ability to share data, and we might be able to break some of this cycle. So I'll leave it at that and say, I think it starts with sharing what we're doing, humbly sharing and realizing we don't have all the data we want and it's not as clean as we want, but we're all probably doing pretty good on process indicators, which is a great start. But if you're going to make the leap and you're going to make a difference collectively in the Carolinas, we're going to have to find ways to get more mature in our data and find ways to periodically redo it.
Good morning, everyone. My name is Lauren Johnson. I am from McLeod Health. I am a family nurse practitioner, and I am the designated nurse practitioner for our school-based telehealth program. So just a quick backstory. I have probably been in this role approaching 2 years in December. So last year was my first full year through a school year doing the school-based telehealth program. Our program initially launched in late 2019. Unfortunately, that nasty pandemic came around and pretty much, school shut down. Everyone was doing learning from home. It took quite a bit of time to kind of get our program relaunched. And that was when McLeod made the decision to bring in a designated provider. With that being said, I will say that our numbers have definitely come more fruitful over that time period. I think initially, like in 2022 and 2023, there may have been 10 to 14 visits total. And I'm happy to say that last school year, we've had over 160 visits. We are a program that is divided between 2 districts in our Florence region with a total of 6 schools currently, with plans to increase that number. So that's just a little bit of background information as we kind of advance forward with my slides. So Donna, if you don't mind, we can go to our next slide. So some of the quantitative measures that we're looking at when we were doing our data, and I will say that a lot of our data was kind of self-driven, self-drawn. We have a telehealth coordinator within our program that, alongside of myself, was able to help capture a lot of this information that we just generated on our own using an Excel sheet. But of course, a lot of this information that you're going to see was also given to us through the school systems themselves. So things that we were looking at is, first and foremost, we want to see how many students are enrolled in each school total. And then with the online registration for our program, we look at how many students that are enrolled in that school actually chose to enroll during registration for the school-based telehealth program. So we provide those ratios as well. We want to look at our total number of encounters, which are the visits that we completed throughout that school year. The average time of each telehealth visit from start to finish. We definitely look at our return to class rate and pair that along with like our instruction time that has been saved with each visit that has been conducted. The total point of care testing. So current state, we offer rapid COVID, rapid flu, rapid strep, and urinalysis testing for both our students. And it's important for me to mention that we do provide these services for the staff members within the school system as well. We also took that number and using the current data for, ER cost avoidance, urgent care cost avoidance, what that may have shown in regards to saving that money with doing school-based telehealth versus utilizing these other services. And then, of course, our biggest thing is looking at our absenteeism rates and how they have transpired and improved from year to year with using school-based telehealth. You can advance to the next slide, Donna. So I'm not going to go through each of these numbers. I know that we all can read very well. So this is just a reflection of our 2024-2025 school year with the data that we collected. So as you can see, we have our 6 schools listed. We look at our total students that are enrolled in the school, and then we will share in the next row there the number of students that were enrolled in the telehealth program. I know with our Duke endowment, our goal is to be as close to 50% enrollment within the program. I will say that from when I first started within this, I think most of our schools were around 20%. And as you can see, we've definitely doubled that for most and at least reached over that 50% threshold. And so I can't wait to see what the enrollment percentages will be for this current school year. That information has not been provided by our schools as of yet. You'll see the total number of encounters that have been completed at each school, our average visit time, which we're happy to say typically ranges 15 to 20 minutes. That's the beauty of these on-demand visits with having a designated provider. We look at our students that have been able to return to class. Percentage-wise, we definitely want to see over 50%. But clearly as many as we can keep as possible at school without having to be dismissed. But unfortunately, there are those circumstances depending on what their diagnosis is where they need to leave. Point of care total testing that we've completed with each school. And then you'll see urgent care cost avoidance as well as ER cost avoidance. And we did take time to look at like inflation rises by looking at United Healthcare. And I want to say the other reference point we used to collect that was Mira Health. Those are links that are attached on my resource pages that can be provided at a later time. And our next slide, Donna. And then lastly, this is just something we kind of did. It's not, set in stone. It's kind of an approximation, just physically showing the benefits of time that is saved with utilizing school-based telehealth in comparison to those students who don't have that access to where generally, in the event they can get an appointment same day, it could be several hours before they are seen and treated, where with using school-based telehealth, the patient can be seen, they can be diagnosed, and there can be treatment within as little as 30 minutes versus, like I say, 3 to 4 hours, or sometimes at the most several days. And that's all I have.
So I'm Amanda North. I'm the Executive Director for Center for Rural Health Innovation. We're in Western North Carolina, serving rural school districts in that region. And since my colleague Lacey Jones is the one who keeps the data and accumulates the data and reports the data, guess who's going to talk about the data? So I'll let Lacey go from here. Thank you.
I'm Lacey Jones. I'm the Managing Director for Healthy Schools. So we are able to partner with 121 schools. That includes 10 counties across Western North Carolina. And students reached, we have around 56,000. And staff reached, we have almost 8,000 that we're able to serve. For the school year 24-25, we were greatly impacted by Hurricane Helene, which was lower than we anticipated. But behavioral health encounters, we were able to complete 227. Next slide, Donna. For our data that we collect, we have a provider survey that we complete through Symposium that we ask each provider to complete after the encounter. So we collect information that includes the type of visit, and that includes if it's an acute, behavioral health, sports physical, or new student health assessment, any kind of follow-up, which includes asthma management, even a dental exam. And then we ask about if the patient was able to return to class or work. And if yes, was it the same day, the next day, or 2 or more days? We also ask about follow-up. So how many visits was scheduled with a follow-up with our own provider, or if they were referred to a PCP or a specialist, including case management. And then we also do a patient satisfaction survey that we send out either email or mail. And we ask the question if how they were satisfied with our services, including if their child was seen or the staff themselves. And then how comfortable they was receiving our healthcare services in the school setting. Were they able to stay at work or other obligations? If it saved them time, as well as if they received better or just as good as receiving care in another healthcare facility, including if they took them to a PCP or ER.
This is Amanda again, just to chime in kind of with a wrap up. From the early days of our data gathering, we figured out that our electronic health record wasn't going to do all the things we needed it to do to be able to report out. And I don't remember how long we've been using SurveyMonkey to collect that side data, but it's something that I would love to hear from some of y'all that you have a better system than a spreadsheet or SurveyMonkey. But I will say that we start our SurveyMonkey every August to ask a year's worth of questions. And it's literally a link on the desktop of the nurse practitioner. So they finish their encounter, they finish their chart note, and then they click that and fill that form out. To give us the details, that the granular stuff that we can't get out of the electronic health record just because it's not discrete data we can pull out. And that's how we get some of our other pieces of info. And I'm excited to hear how other people make that happen, actually operationalize gathering the data. So if that wasn't already in your notes, please talk about it.
Thank you. Hello, good morning, everyone. I'm Denise West, and I'm honored to present on the impact of our Novant Health school-based telepsychiatry program as our team's program coordinator. Today, I'll walk you through the scope of our services, the impact we're seeing, and how we're using our data to continuously guide and improve our work. So in general, regarding our services, our team provides virtual mental health services, including crisis assessments, short-term bridge therapy up to 6 sessions, and case management. We operate in schools across multiple counties and work closely with our school staff and families to ensure timely access to care. One of our key goals has been to reduce emergency room usage by offering an immediate virtual mental health response in the school setting. So our data collection serves 3 main purposes. First, to measure the effectiveness of our services. Next, to inform decisions like where to assign our staff and what resources are needed. And then lastly, to communicate our impact clearly to our school partners, healthcare providers, and community stakeholders. We do collect reach data to understand who we're serving and where our services are needed the most. This includes school names, student demographics such as age, race, gender, city of residence, as well as type of insurance, and a history of mental health services. We also collect information related to case management needs such as food insecurities, housing and transportation barriers, or safety concerns. This data helps us to identify any underserved populations and direct our outreach accordingly. So our outcome or our impact data speaks directly to the effectiveness of our services. Since our program's inception back in 2021, we've conducted over 600 virtual mental health assessments. Our referral rates have increased by 20% each year on average, which has been a sign of trust, growing trust and visibility within the communities we serve. More importantly, we've averaged over 93% of students being assessed through our program being diverted from our local emergency departments. Most are successfully connected to long-term outpatient therapy within 2 weeks of our interventions. So behind the scenes, data collection has been a core part of our model. Um, we use intake forms, encounter notes, and referral logs similar to the ones displayed. This is tracked manually in Excel, and our staff enter data after each encounter. We do conduct weekly and monthly reviews to ensure accuracy of our data, and then as well as our leadership team and myself, we will review and regularly monitor the trends and identify areas of improvement as needed. But there are challenges. So, like previously stated, manual entry is time consuming and subject to human error. We currently lack a robust automation and visualization tools, which does limit how we can effectively uh, analyze and share our data. That's why we're prioritizing our next steps, like implementing a digital platform so that we can improve that visualization of our data and automation, as well as our next steps also including creating a form of standardized template so that data entry can be consistent across all team members as we continue to grow. The ultimate goal for us is a scalable model that other programs can easily adopt. So in closing, our program is just one example of how school-based virtual mental health services can meet real needs in real time and how data can drive that mission forward. We do look forward to sharing more, but learning from everyone and continuing to grow with our partners in education, healthcare community, and the media.
I'm Misty. I'm the nurse practitioner with the Prisma School-Based Health Center. Just to get started with our reach, so on our next slide, we have a map here that shows where we practice, and our model is maybe a little bit different than some of the other centers that we have here today. We are primarily an in-person clinic, so we have 5 different Title I schools that myself, I'm the sole provider that's practicing in these schools now. Myself and our clinical coordinator, every day we travel to a different school and we see patients there in person. We do offer telehealth visits, so we are always available via telehealth. We have had, working on engagement with the school staff when we're not present to really utilize those telehealth services. So that's another reason that we're excited to be part of this collaborative, is to learn how other people have engaged the school staff, like the nurses, to feel comfortable using telehealth. But so our schools, Title I schools, you can see here, we do have 83 to 90% of our students are classified as living in poverty. The approximate number of the total students in these schools about 4,400, and primarily, many of our students are multilingual learners. We do see a higher chronic absenteeism for these students. So compared to the rest of the state, you can see those numbers there. Our students, and these are our on-track schools, meaning this is a program that we work with through the United Way, who helps to fund and connect us with different resources. for these students and their needs that they might have. And then you can see our race, ethnicity breakdown. So this is just a general idea of the students that we work with. So we do use TytoCare. We have a team with Prisma that is led by Lisa Copera. Ethan Cordy is also working with Lisa to help train our nurses and make sure they have the infrastructure, the digital infrastructure to provide the services within the schools. So they are always available to the school nurses if they need any help. So you can see our numbers initially were quite a bit higher. And then when the provider left and then I replaced the previous one, we're hoping to get those numbers back up. We do have a data reporting system. Like many of y'all, we do track it manually in Excel. Our clinical coordinator with every visit will track just based on these different categories, which visit that one falls into.
Because of our partnership with the On Track program, a lot of the demographic information we get on the schools is filtered through them. Greenville County Schools is very protective of school-wide data. And so data agreements with them are hard to come by. So we often have to rely on the On Track program, who does have a broader data agreement with them to get us school level data. So we focus primarily on visit level data. We've had various funders throughout our 8+ years. So some of our data collection was kind of led by our grant deliverables and reporting structures, but not all of it. There was some information that we started collecting that we knew would help us and guide us in our services. Because we are primarily in person, where we are on what days and how often we go to schools is often dictated by volume. We go where we're needed. So we utilize that data to help guide us in those decisions. Our telehealth presence is very much relied upon by the engagement of the school nurse. There's a high turnover at these schools for school nursing personnel. We do have to rely on them to be our telepresenters. So that means they have to initiate the referral to us for that acute visit, and also, be able to navigate the iPad TytoCare. We're still trying to find the magic formula to get that engagement to where we could utilize our telehealth services better.
Good morning, everyone. I'm Hannah Dale Barnett. I'm the Research Associate with Healthier Lives at School and Beyond out of East Carolina, here in Greenville. And I'm joined by Dr. Skip Cummings as well. And Dr. Cummings, I would love if you could give us a quick overview of our programs.
Thank you guys for the opportunity to share a little bit about our program. So our program's been going on for at least 9 years now. And we have grown from starting out with initially 3 schools in Duplin County, a very rural county in southeastern North Carolina, to now in 5 different counties in rural eastern North Carolina. And we've grown cumulatively to over 5,000 encounters now. We provide not only acute minor medical care in partnership with Amanda and Lacey, who are on here as well, but also provide behavioral health counseling as well as nutritional counseling for students.
So along with encounter information and demographic information for patients, some of our reach data metrics include looking at % of non-white patients served, really focusing on those health disparities in our rural areas. The areas that we serve are majority non-white patients, so the goal would be to serve the majority of our patients. We use the EHR records along with NCDPI statistical profiles for a lot of our metrics, so I have that bookmarked. So all the NCDPI folks, I truly appreciate your data. We look at patients who don't have health insurance, and with our goal being to reduce the financial barriers to healthcare, really bringing those services to our patients and not having insurance be a limiting factor for them. Looking at school district participation participation by number of patients served in each school or each district, and percentage of patients served utilizing an interpreter. In Duplin County in particular, there's a high primarily Spanish-speaking population, so wanting to make sure that those services are equally available for them as well. Our data sources do include EHR records, and like everyone else, we do have internal spreadsheets that we use. So I'm sorry I don't have the magic formula, but I'm thrilled to hear that everyone else uses Excel. Our providers do share encounter level information with us through REDCap, which is a HIPAA compliant web-based software that the UNC system has access to. I think other systems may have access to it too, I'm not sure. But after each encounter, the provider also fills out information, and then I go into the EHR and look at registration information. Next slide, please. And then, as Dr. Cummings mentioned, we do have nutrition, behavioral health, and acute medical. So Lacey provides us some awesome time away from class data, and I'm so thankful for her. I know it's not easy to collect this data. We also look at transportation barriers to care, the estimated miles of patient travel saved. This is a rough estimate, and there's some generalizing that has to be done in order to just be mindful of PHI, but we look at the estimated miles saved round trip from the patient's school to assumed place of in-person care, which does vary by school and school district as well. We assume, again, where the patient would go for the in-person care and calculate from that point. We also look at just the average number of encounters per patient by service. Our behavioral health services, they typically range somewhere between 6 and 12, probably closer to 6 and 8 appointments per patient before they're either discharged from care or referred out to another community partner as well, which is information that is provided by our providers on the encounter level data. As mentioned, the time away from class, and for behavioral health, we're looking at changes in depression screening scores from close to initial intake to the final discharge, typically using PHQ-9s, but some providers prefer different screeners, which can make it a little tricky to generalize that data. For nutrition, we look at changes in patient BMI from intake to discharge as well, along with, overall general frequency of diagnosis and I said demographics as well. But yes, we have found challenges in getting EHR reports that gather all this information. As CRHI mentioned, some of the information we need, like return to class time in particular, is not, you just can't pull it from the EHR. So we are still looking for ways to enhance that as well.
I was just going to say, if I could add, we have been fortunate enough to be able to hire a telehealth logistics coordinator in many of our communities. So this is somebody who's local to the community, has a boots on the ground experience, and can help connect that child from the classroom often to the school nurse's office, connect them then to the equipment and for the telehealth encounter, present the patient's concerns to the provider, and then work with the school and parents with any follow-up needed.
So we can show you a couple of the initiatives that we have here. So first off, I just want to highlight, I know this is different than everybody else's with this initiative, or maybe you have this in your schools, but we do an education after school session, and we do this through telehealth. Through PEXIP, which is a platform. It's basically like a souped up FaceTime with the kids, where we're able to get 5 schools that are pretty rural in Richland County, which is the heart of South Carolina. And we're able to reach them and do 30 minutes of health education with them that incorporates a lot of visuals, a lot of movement. We use a tool called Go Noodle, which some of you may be aware of, that are used in schools. And we're very purposeful about how we provide and present that information. We partner with our Department of Public Health, their SNAP Ed team, along with our community health employees. We provide that once a week session. We do 16 sessions over the course of a year. So it's pretty exciting to see the kids. We do pre and post surveying and results. And so far, I mean, sometimes we get some great engagement with pre and post tests, and sometimes it just kind of stays the same. But we are able to see a little bit of lift with the amount of water that students report that they are drinking, the amount of activity that they're getting. A lot of the lessons are around nutritional health, sleep health, screen time, that type of thing. So we use a curriculum called Catch, which is what our Department of Public Health uses. This kind of incorporates healthy eatings with My Plate, and just how to navigate snacks and foods. And we also try to make sure that parents are involved as well. So it's kind of the whole child, the whole family approach to doing this. And again, we do this through telehealth, and we've been doing that program since we first got a USDA grant back in 2017. As we look forward to our upcoming school year and the challenges presented with federal funding for our SNAP Ed teams, we are going to pause for this upcoming semester and really try to reimagine what a school-based after school telehealth program will look like in maybe some different areas and different schools, potentially using a different curriculum and different partners. We want to use our SNAP Ed team, but as we know, the federal environment is not as supportive of SNAP Ed education currently. So that's our EDU program, a clinical program. We actually had, we put that on pause this past year because our nurse practitioner, we partner with our Bradshaw Institute with Prisma Health. And we just had to really pause this past year because our Midlands provider was not available. We do now have a Midlands provider, and we are excited about our upcoming school year and kind of relaunching our telehealth program. But this is a telehealth only type of methodology. We only do we use the nurses, the school nurses, they use the Tyto product to contact our nurse practitioner. And we really work on that school district partnership, and we utilize our palliative care connections and our virtual digital health team at Prisma Health to help provide these services. So similar to you guys, we have an internal spreadsheet that we use to look at this. This is actually some data over the past 2 years, again, excluding last year, but we do look at, what that telehealth visit, how many minutes we use. We're looking at the emergency room cost avoidance. I liked somebody's slide who used the urgent care cost avoidance, so that may be something that we take a look at as well. And then that chronic absenteeism, we will be working on that data point for our coming school year, but we looked at the potential school hours missed if telehealth was not used. We just do acute, kind of non-acute visits. So we don't do anything right now with behavior health. We don't have a process to do medication or screening tests such as, flu, COVID, etc. But that is a future goal as we relaunch our program. And again, we appreciate all of the support that the Palliative Care Connection gives us and our own teams And we do have a strong partnership with our upstate teams. Melinda Lavely Turner and I work closely to make sure that at least, a lot of our processes align when we're doing our telehealth. So we're looking forward to our next school year, and hopefully next time we do a data report out, I'll have some new numbers for our school year.
Hi all, Dr. Rachel George here. I am a guest visitor today, so thank you for having me. I've loved listening to all the different data you all collect. I am a senior evaluation scientist. I sit on our impact evaluation and grants management team, and so I support Patsy and her team and our school-based virtual care operations doing all the data pieces, which is why I'm just sitting here taking notes on everything y'all are saying. Our school-based virtual care program started in 2017. I only joined in 2024, so I cannot take credit for all the great work before I got here. But we have since grown to be in 9 counties, 8 of them in North Carolina, 1 in Georgia. This past school year, we served over 11,000 patients across just over 15,000 visits. Thinking about the different types of data we collect, here I was focusing on process metrics, so kind of checking in on how is the program growing and how is it being utilized. So left side of the page, I organized this by volume related metrics, looking at the number of sites that school-based virtual care sites that we have, whether they have launched, whether they've had visits at them, or whether they've launched but haven't had visits there. The school that the site is at, so whether it's a Title I status school or not, the school level, elementary, middle, or high, as well as the location, what county is it in. We also are able to look at number of patients and visits by location as well as school year over time. The number and percent of patients by demographic, so payer, race, ethnicity, sex, and patient type, whether they're a student or staff member. We also report out on primary diagnosis. There are some other metrics that we could add here. These have been the ones that have been most informative for our operational team, but I was really intrigued by the average visit time that some of you mentioned, and I think that could be really interesting to look at here as well moving forward. Let's see. I have pulled historically data from the National Center for Educational Statistics to look at the number of students enrolled in each of the schools that we're located at, and then compared that number to the number of patients that we are actually serving through school-based virtual care. So we're able to look at that utilization number, percent of patients by school enrollment. And then also using that National Center for Education Statistics data resource, I have compared the percent of patients by sex and race ethnicity that we serve in school-based virtual care to the percent at that school. So we can kind of get an idea of, are we over or under serving certain demographics? Are we reaching the students that we are hoping, the patients that we're hoping to reach? And I will say all of these, the volume data all come from the clinical pieces, all come from Epic. They're updated daily. So we've actually worked with our data, they're almost a data scientist kind of data wrangling team. And so they were able to create what's called a data mart for my team to then connect to. And so that data mart is a snapshot essentially of the data specific to our school-based virtual care programs. And then I connect to that data mart using Power BI, which is also a Microsoft Office suite tool, which it can help with visualizations. I heard some people talking about Excel and kind of the manual entry there. I think Power BI could be a potential solution to explore. And so I connect to that data mart via Power BI, and I'm able to pull that clinical data to then represent it visually on the page. So then thinking about some of those outcome metrics. So these are looking at our clinical outcome metrics. Some of y'all have mentioned this already. We look at number of primary care, attribution to primary care, as well as wellness visits in the 12 months pre and post that school-based virtual care patients index visit. We also then look at hospital admissions, length of inpatient stay. We can get access to urgent care. We haven't looked at that historically, although I heard someone mention that, and I'm interested. And we do also look at emergency department utilization. I have a little asterisk there because when the program first launched in 2017, it was a very high touch model, and we were seeing decreases in AD utilization for our patients. However, as it's expanded to be across these 9 counties, the model has shifted slightly, and we're no longer seeing that same decrease in ED utilization. So I am curious kind of how you all are seeing those trends in that data. And then from the school system, kind of looking at school metrics outcome side of it, we have 2 data sources essentially. Thinking about absenteeism in particular, at the end of each school year, I submit a data request to our largest county that we work with, Mecklenburg County, for absenteeism rates for the schools that we are providing school-based virtual care in. And so each year we can get a chronic absenteeism rate from them for those schools. That is at the school level, so it's not quite specific to our patients. And so again, for that county, for Mecklenburg County, my team is also working with what's called a local integrated data system to get a data set from them that has days absent for each of the patients who we've seen at school-based virtual care. So essentially, and there's been a lot of legal agreements, as I'm sure you can all imagine, we share a list of the patients that we've seen through school-based virtual care in Mecklenburg County with this local integrated data system, and they are going to send us that same patient list back, but it will also include some of the school system data. So we'll be able to see for each of those patients how many days each school year were they absent, and did that absenteeism decrease following their use of our program. This will not happen annually. It probably happens about twice every 5 years, just because it's a big lift on both sides. But we are very excited to get some of those data, and what you're looking at here, that's where we'll get those data through. So like GPA scores, graduation rates, retention rates, that will come through that integrated data system. So then just this past year, we also launched what we're calling an implementation survey. But again, this was specific to Mecklenburg County. We are administering it through REDCap. So a survey going out to schools and nurses at our school-based virtual care sites. And we were trying to understand, we're kind of seeing some schools that are really using our program and some that really aren't. So trying to understand what's happening there. We got some really interesting feedback about the program back from that survey, and I'd be happy to share the questions we used if folks are interested.
Thank you so much, Donna. Again, my name is Deborah Moore, Program Manager for Cone School-Based Telehealth. We're excited to be entering to year 4 of operation of our program. All of this is under the leadership of our Medical Director, Dr. Jenkins. So we're covering a large geographic area in 3 counties here, Guilford, Rockingham, and Alamance. And from the beginning, when we originally started, our focus was to serve populations with Title I schools. And as we've continued to expand, we're working with all 3 districts, allowing them to identify and select the elementary schools with the highest need, and making sure that those elementary schools also have the capacity to house a telehealth clinic within with a confidential space. Next year, our school year, we plan to expand to 40 sites with a projected increasing our encounters from over 10,000 to over 17,000. Those 40 sites expansion will include 10 additional sites in Guilford and 1 each in Rockingham and Alamance County. As you all know, Dr. Jenkins, he is a visionary. So over the next 5 years, our goal is to expand to 80 sites across various counties in the Triad. Here we're going to look at a comparison of our current methodology with what we'll be initiating in the next school term. Again, our current data tracking today, we too have utilized the spreadsheet, so it's nice to know that we're not alone. Power BI app, as well as surveying our parents and our school personnel. In addition, we've been working with our Cone Analytics to analyze some of our ED utilization as well. In the upcoming year, we'll be looking to integrate more in our Epic system, which should allow us to do some automated reports and hopefully decrease some of our usage of the spreadsheets. We've also implemented templates to increase speedy documentation as well as consistency for our CMAs. And the last thing we have worked on is developing a new visit type. So currently with our delegated visits, we will be entering those into our Epic system, and that will align with if you were in a primary doctor's office, that visit would be similar to like a nurse visit, and they will be able to enter those delegated visits for that visit type. So we're excited about that. As we continue to progress with different prototypes, we will include a prototype with point of care testing, as well as integrating our behavioral health assessments, recommendations, and brief interventions. And that prototype will also include adding our community healthcare workers to focus on our social drivers of health and care coordination to support our behavioral health prototype. So from year 2 to year 3, we saw tremendous growth in our program. As you can see, we went from over 3,000 encounters to over 10,000 encounters in this past year. You'll see that 3,000 of those rose to the level of needing a provider. And this year for our virtual encounters, our nurse practitioners also saw a significant increase in the amount of virtual visits that they saw. So we were averaging about 40 visits per day in the 26 schools that we covered this past year. So we strongly feel that a lot of those visits were driven by the fact that we did have a full-time telepresenter in each of our schools, as well as working with our schools to increase our consent percentage. So we were averaging about 45% of the students were actually consented in the schools that we were in. And we realized that 89% of the encounters allowed the students to return to class the same day. And in looking at our payer mix here, you'll see that 84% of the students that we served were receiving Medicaid, and the additional ones fell within commercial and our uninsured, which we utilize scholarship funds to cover our uninsured population. So last slide, we want to highlight some of our data that we collected with Guilford County Schools for year 23 and 24. Overall trends, we showed an improvement in attendance, improvement in math scores of the schools that had telehealth, and then 9 out of the 14 schools showed a higher reading score, and 10 out of the 14 schools had fewer office discipline referrals. So we're excited and we expect that even better impact as we wait to get the results for the 24-25 school year. With the 10,000 encounters, we anticipate that we will see more trends of impacting in those schools.
So I just want to add, one of the things that we're really blessed with is Deborah. Deborah is the queen of the spreadsheet. She is also a person who has really put discipline into the things that we measure so that we're creating a database that we can make some really good inferences from. I'd also like to emphasize on that visit type in Epic. That's something that we convinced our system to do a build for, so that we now have all of the simple encounters that are for Band-Aids, ice packs, just encounters for reassurance, which because we're in the school full time, those result in a lot of return to the classroom. In fact, those are our highest rate of return to classroom. Almost 100% of those encounters result in the child returning to classroom. Historically, those were referrals from the teacher that sent to the office for the child to be sent home. We're documenting those in Epic, and to do that, interestingly, what we've come across with our IT team is to create dummy CPT codes so that we can track what those visits are for and create a database for what those visits are like. The team sitting beside me right now have written dot phrases and encounter phrases so that the CMA telepresenters can quickly document those visits and also end up getting the information into the visit so that we can write reports to understand what those brief encounters are doing.
Thank you. Hi, everyone. Thank you for letting us join and present. I put together a few slides in conjunction with Dr. McGeorge and Dr. McElligott that I am happy to help share. Our physical health program has been around for well over a decade, and we offer both telehealth and in-person visits, on-demand acute visits for any normal childhood illnesses, chronic condition management visits for things like ADHD and asthma, education visits for patients with an asthma diagnosis with a pediatric respiratory therapist, and new this year, collaborative care management. We also are working on, Dr. McGeorge has a program, Wellness Works, that we are piloting in a few of our schools as well. So next time we share, hopefully we'll have some data on that. And then our behavioral health program launched in the 23-24 school year. They also do telehealth and in-person visits, on-demand acute visits for crisis management. They offer therapy and psychiatry visits. New this year, we're partnering with them to do collaborative care management in schools. And also they have a day treatment program that is new for them this year. Here's just some quick facts. For physical health, we are in about 120 schools with over 50 more contracted for this school year. We have had some schools merge or close. So our numbers have bounced around a little in the 120s to 130s, but we are currently at about 120. We did 2017 physical health alone visits in the last school year. 132 of those were acute visits performed by school nurses. And we do track seat time via a red cap survey that Dr. McGeorge built. So basically we ask our providers to track how many of the students they're seeing for an acute visit, and then to let us know if they were able to return to class. 95% of the students seen for an acute visit who were able to return to class for not being infectious or otherwise were able to return. So that is our something we like to share with the schools. As far as behavioral health goes, they currently have services in 106 schools, so super rapid expansion, which makes sense with the need we currently have. And they're also contracted for more than 50 schools here over this next school year. They did close to 5,200 visits between therapy and psychiatry. And last year, about mid-year, a little later than mid-year, they did start taking acute visits. So they have an on-demand service as well, where the student can link to a provider immediately. And they completed 15 of those visits this past school year. So a few key points. Right now, most of our data is pulled through Epic. We do have some ability to pull through RedCap, some different things. We have the cubes that we use, which pull data from Epic. A lot of it is manual. We do have a data manager who is working on creating some dashboards for us, so things have a little more automation to them. But right now, a lot of what we pull is from data, or is from Epic. Our partners are asking for outcome data that we are working on finding ways to pull that data, some different things like ED cost savings, and the number of students consented by school. It is a little tricky for us because our consents cover the child the entire time they're in a district. And so it doesn't report to us the school that the child attends, just the district that they're in. So it makes it a little hard to kind of track down where the the child goes to school. We've also not been able to find a great way to project ED or urgent care cost savings. A lot of it seems to be subjective based on what could have been saved or could have been spent. So we're also still looking on a good way to show that. And then we do send our data to partners, some monthly, some quarterly, and some annually, pending their preferences. We send it to superintendent, district leadership, as well as the lead of nursing for each district, just so we can be very transparent with who's using the services, who's not using the services, and how we can help to support them if they are not using the services. So this is just some of the data points that we track by service. How many visits were telehealth versus in person, how many were acute visits versus chronic, and for what diagnoses, how many education visits. For collaborative care, we will be creating some new data sets there this school year. We do track seat time. We track utilization by provider, by school, and by program. We keep track of our top diagnoses, and then Epic also tracks demographics for students that we can pull manually if we are in need of that. And we always track the number of active schools by program, and then the number of visits per school and per district. And this is just a screenshot of kind of some of the metrics that we're tracking, that we're reporting up. I pull the data and it then flows up to our Director of Operations and Nursing, and then up through Dr. McGeorge and Dr. McElligott for their review. So these are just some of the things that we're currently tracking and working on building to track. So I wanted to share that if that's helpful to anybody.
Interesting. This has been incredible. I think all of us believe that we have learned so much from listening to each other about what we're measuring, what kind of impacts. There is a model that's getting national attention from funders. Kaiser Permanente and the Kaiser Foundation use this model to really group outcomes, reach data, and impact data in a way that can be reported. And so this is kind of like file folders that we hope to develop for the collaborative, so that we can start defining the data in the same way, collecting the data in a similar way, and then being able to report out a community impact statement for telehealth across North South Carolina and into Virginia and even into Georgia, where our programs reach. So the REACH data was exciting. You guys really covered this really well. You talked about the eligibility, enrollment, location of services, the vulnerable populations that you serve, looking at the high poverty populations, looking at race as a REACH factor. I love the fact that we are also using REACH data to guide where we might go to the next school, to the next area we might render services, by indicating where there were high poverty, high disenfranchised populations, so that we can know and direct where we grow. Numbers of students consented was talked about. Demographics definitely was talked about. The quality and type of services by whether or not they were a brief service or a video service or an in-person service, and even by the type of service rendered by diagnosis. The numbers of schools, the numbers of counties, the numbers of areas that were covered were all discussed, and we'll look at this and REACH data. Outcome data was very variable amongst all of our members today, and the quality and quantity of the services that we have, what educational metrics we were changing in terms of the time the students had in class, absenteeism data. The problems with measuring those outcomes were also significantly discussed today, and maybe today, as going further, as we work together, we can find ways that we can reach out to our school districts, reach out to our statewide databases like DPI to get these statistics more readily. Absenteeism rate, early dismissals, academic performance, behavioral instances, emergency room, urgent care utilization were all mentioned by those giving presentations today. Impact is where the dollar meets the road, so to speak, because impact shows our value to our states, to our schools, to our communities. And how can we show that we're impacting health expenditures, How can we show that we're keeping children in their seat in schools, affecting school finances? Is there a measurable impact on students' potential? I love the fact that we're looking at both short-term and long-term impacts. So looking at graduation, advancement rates, but also looking at their math scores and their reading scores. And then how do we affect the impact of families and the communities? We heard discussions around miles traveled by the families, which is a real important marker of expense to the families, hours missed by survey from work or when they had an early dismissal, and then the impact on families of having to go to the emergency room and the urgent care. So I think that these are going to be really important.